improvements. So what I am going to address today, and I will not go through a background because I'm aware of the time is short, and so I cut to the chase and go straight to the main question we were interested in when we started these studies, and that is what is the precise nature of the link between atrial fibrillation and left ventricular dysfunction. So the options are, of course, at least two, and that is causation, and this is what has been shown by animal study that has shown that atrial fibrillation and uncontrolled ventricular rate can lead to left ventricular dysfunction. Under these circumstances, recovery of sinus rhythm should lead to an improvement of left ventricular function. So the other is just simply a correlation, and that is we may have an underlying cardiomyopathy that is causing both left ventricular dysfunction and atrial fibrillation, and this is the case, of course, of patients with heart failure, but I wouldn't go, I'm not talking about that, I'm talking subclinical. And under these circumstances, therefore, recovering sinus rhythm may not have a beneficial effect on left ventricular dysfunction. So to address this, try to address this question, we looked at patients with paroxysmal or persistent atrial fibrillation undergoing catheter ablation. And we chose a particular group of patients, what we called lone atrial fibrillation. Nobody likes this term, but you know what I mean. So if you look at the exclusion criteria here, we excluded everybody with a poor ventricular rate control, with significant coronary artery disease, valve disease, diabetes, uncontrolled hypertension, and metabolic and inflammatory diseases. So we also then looked at matched control in sinus rhythm. So we looked both longitudinally and across. So we did that by using cardiac MR. This is just a CNA MR, and I want to specify that all analysis that I have shown today are done with the operator blinded of whether the patient was in atrial fibrillation or sinus rhythm, and this is possible because they just see one cycle averaged for each patient. So, and then I also am not a fan of, sorry, I'm just being, yeah. I also not a fan of left ventricular ejection fraction, so we also looked at TAG MRI for the assessment of myocardial strain. All of this was done at 1.5 Tesla, and at 3 Tesla, we did a 31 phosphorus magnetic resonance spectroscopy to evaluate a marker of myocardial energetics, which is the phosphocreatine to ATP ratio. So these are the characteristics of the patients and the control, and you can see that they were middle-aged patients, not with no particular strong risk factors. So we looked at 53 patients with atrial fibrillation, and the scans were done before the ablation, early after ablation, just to look at the effect of reversing atrial fibrillation into sinus rhythm without, though, having the time to go through any remodeling that may happen as a result of the sinus rhythm. And then a late visit after about 7 months to look at the later phase. I mean, how do patients who recover sinus rhythm and sustain a recovery in sinus rhythm do at that later stage? So we looked at resonance spectroscopy before and at the late endpoint, left ventricular function in all 3 points, and of course the controls had both on one occasion. So if we look at the results before ablation and compare patients with controls, what we see is that left ventricular end diastolic volume is not different between control and patients, but the end systolic volume is increased in patients, and this results in a reduction in left ventricular ejection fraction. And so much we already knew. We then also looked at the circumferential strain, and we see the patients have a less negative circumferential strain, which is an indication, of course, that there is a mild impairment of left ventricular systolic function in patients with lone atrial fibrillation and no particular risk factors. So then, and this is new, we looked at the resonance spectroscopy and we saw that patients had a significantly lower phosphocreatine to ATP ratio. The difference that you see here are small, but we can only see small difference even in terminal heart failure with these parameters, which has been shown to be independently related to outcome in patients with cardiomyopathy. So atrial fibrillation is associated with impaired myocardial energetics. So then we looked at the effect of the intrascan rhythm. Did it make a difference whether the patient was in sinus rhythm or atrial fibrillation at the time of the first scan? And this is what we found, and that is that in patients with paroxysmal atrial fibrillation who had a significant AF burden but happened to be in sinus rhythm at the time of the scan, there was really no significant difference, as shown here, in left ventricular ejection fraction, whereas in those who were in atrial fibrillation during the scan, there was, these are the ones that drove the difference in left ventricular ejection fraction. If we look, however, at myocardial energetics, both patients who were in sinus rhythm or AF at the time of the first scan had a similarly depressed myocardial energetic index, as you can see here. So before ablations, the patients in IF during the scan have a lower left ventricular ejection fraction versus those who were in sinus rhythm, but left ventricular energetics are equally impaired. So what happens after ablation? Well, ablation here was very successful in recovering sinus rhythm in the duration, for the duration of the follow-up of these patients. So you can see here what was the intrascan rhythm first and the first visit. And then you could see that after ablation, in the very early first visit, 94% of patients were in sinus rhythm. And 7 months, 87% were in sinus rhythm. This is during the scan. We also did 72 hours Holters, 7 days, Holters, as well as monitoring over 3 months of intermittent heart rate. And you can see that there is a massive difference in the IF burden in these patients over this time. So would this affect the indices that I've just shown you? So this is the left ventricular ejection fraction, and you can see that early post-ablation there is very little difference, and late post-ablation we reach statistical significance because we have a very reliable and reproducible measurements in the MR ejection fraction. But the change is very small, and the left ventricular ejection fraction in this patient is still lower than in the matched controls. So it is improved modestly, but not normalized. So then if we see what is actually driving that small improvement, again, we see the importance of the rhythm during the scan. So pre-ablation, those who were in atrial fibrillation but then turn into sinus rhythm, you could see that there is an increase in left ventricular ejection fraction. Those who had AF but happened to be in sinus rhythm during the first scan, you could see that this did not change. And by contrast, if you look at myocardial energetics, both pre-ablation and post-ablation, there is still a lower measurement index than in control. So there is no normalization of the myocardial energetics despite recovery of sinus rhythm in these patients. So in summary, before ablation, atrial fibrillation at the time of the scan, compared with sinus rhythm at the time of the scan, is associated with a lower left ventricular ejection fraction, but energetics are equally impaired, irrespective of the intrascan rhythm. So after ablation, left ventricular ejection fraction improved very modestly, but did not normalize. And that improvement was mostly driven by the switch to sinus rhythm at the time of the scan, rather than by a reduction in AF burden over time. So post-ablation, the myocardial energetic remained unchanged, and despite the substantial and sustained reduction in atrial fibrillation burden in these patients. So how might we interpret these results? So what we know from animal studies is that atrial fibrillation causes atrial remodeling and can equally cause left ventricular dysfunction, as I said before. And if we attacked this early on, or we decrease the ventricular rate, as it may happen as a result of a successful catheter ablation, we should reverse left ventricular dysfunction, and to some extent maybe also atrial remodeling, depending on the stage of IF. So this is what we know from healthy animal in which we induce atrial fibrillation. In patients, the story may be completely different. And what it may be is that we have an occult cardiomyopathy due to exposure to risk factor or aging, not dissimilar to what is the left ventricular failure with preserved ejection fraction. And that can then affect myocardial energetic, leading to some subtle left ventricular dysfunction, then feeds back to atrial remodeling and causing atrial fibrillation. So if that were the case, and as the results suggest, the treatment of atrial fibrillation and our idea on how we manage atrial fibrillation may require a significant shift in our approach, and so we should really focus on prevention, risk factor management, and ideally, if we could find some, therapeutic strategies that are upstream of the atrial ion channels. So I just show you the editorial that accompanied our paper, because I think it's absolutely nailed the point. And I read, just as few physicians would expect a stent to protect a patient from progression or reoccurrence of coronary artery disease, our view of IF ablation may ultimately undergo a similar paradigm shift. After plaque stenting, statins, and lifestyle modification are used to target the underlying pathobiology of coronary artery disease, we may also find that adjunctive therapies are needed in IF to target the ongoing drivers of the disease process. So with that, I'd like to thank Rowan Vijay-Surender, who has done most of the scan and the work underlying this paper, and the Oxford Biomedical Research Centre and the British Heart Foundation for funding this study. Thank you very much.
Thank you.